Hello, I'm Barbara Holding from Canine HS Courses, and I'm delighted to welcome you to the next in our series of bite-sized canine anatomy. And I'm really excited because this has been very responsive to what you wanted to have presented. So we put a poll out and it was fantastic because we're listening to you and we're now looking at the shoulder joint today. So again, your feedback really helps us know what you would like to have. So we've got a really full house today, and so I just want to welcome people new to this bite-sized interactive event and just orientate you around this platform, which is a brilliant platform. It would be great if you can give me some feedback, make comments as you go along. And if you wish to ask a question, please don't put it in the chat, which is on the right. So your chat box is in the bottom right for you to write your comments. But if you've got a question, please put it in the ask a question, which is along the bottom navigation bar. It's got an upvote. So if you see a question you really like, you can vote for it. And I can timestamp them. So I'll stamp them before and after. And then if you want to go and listen to just that question and answer, you can do that after the event. And the event, if for any reason you've got issues, it'll be your Wi-Fi, refresh your page, or the replay will be available literally minutes after we finish. So all professional canine hydrotherapy centres, all professional canine therapists are at home. We've closed our businesses in response to the government, the BVA and the RCVS. And because of that, we've designed something especially for you, for the people who've been following us and sending in feedback, sending emails. I'm so grateful for your emails, your feedback, your comments, your questions that you email through to us. So I'm going to talk about what we've got planned for you, but you know, it's really exciting, it's brand new, and you know Canine HS do things a bit different. So it's using tech no one else is using yet, just like the Crowdcast. We sort of launched that in the UK and it was a little bit new at the time, but it's a great platform to share questions and reach the global community of canine therapists. So I'm going to start the presentation. There we go. I've got Sarah in the chat. So Sarah's in Cambridgeshire and she's remotely helping me in the chat box. I'm in Norfolk and it's great to see where everybody's come from. So it's fantastic. So we're looking at the shoulder joint. So let's think of some facts. This is a ball and socket joint. It's also known as a spheroidal joint. And the ball is the head of the humerus. So if you have a look where the blue arrow is, the head of the humerus you can see is huge. It's about double the size of the glenoid cavity. Now the glenoid cavity is part of the scapula, and that's with the green arrow, and that's much, much smaller. So there's not a great anatomical fit. So it's very loose. So it's something to think about. So what kind of range of motion do we have at the shoulder? So, well, basically all movements. It's designed so it can go in all directions. So it can do flexion anatomically, extension, abduction, which is away from the body, adduction, which is towards the body to the midline, lateral and medial rotation, and circumduction. However, in the dog, it's completely different. So in humans, we have that facility for a ball and socket for all the amazing activities we wish to do. In the dog, the four legs are about two things: supporting the dog against gravity, and for acceleration, the dog is designed to move forward in the sagittal plane. So physiologically, functionally, in the dog, it's really different. It's actually main movements are flexion and extension. And that's what it needs to be able for the dog to be able to do their day-to-day activities and to move in natural balance stance, to be in natural balance stance, different postures, and also to move in natural balance motion. So let's look at these shoulder joint facts. Functionally, the range of motion is specifically flexion and extension. So I've given a little bit of just a review for your anatomy here. So the pink arrow is the spinous scapula, and at the bottom of the spinous scapula on the distal end is the acromion. That's the yellow arrow. Anything that's a knob or a bump has something usually quite significant attaching to it. So these knobs, bumps, spines give attachment to the muscles, and the muscles, the contraction of the muscles, are what give the dog power to move. But we also know they're very important as stabilizers. So your forelegs, your thoracic limbs, are all about specifically shock absorbing and braking. Whereas the hind limbs, which are zigzag, is a brilliant design for powering. And the dog powers using the muscle, the power muscles, that's pushed up through the spine. So the epaxials is kind of like your car axle. It's really important. It's strong and straight and true to push that power up, and the dog is designed to move forwards. That's why we never would dream of walking a dog backwards. It's not useful for the dog. And when we go through some of these structures, you'll realize it actually jeopardizes the stabilizing structures. So we're going to therapeutically move the dog in the direction it needs to use, because I have never seen a dog running backwards, but I have seen dogs run forwards to chase squirrels, balls, have a wonderful time, to come and greet you. So let's think our therapeutic choices around that. So we've also got the teal, the aqua teal arrow is the greater tubercle of the humerus. Now, it's not just one little bump, it's quite expansive, and it's got like a flattened area just next to it as well, which is a really important attachment for a structure we're going to talk about. And then we've also got the blue arrow going on to the head of the humerus, which you can see is nearly double the size of the glenoid cavity. Thank you, Jane. It is. I got so carried away. We don't need to be seeing me. But don't worry, because when I tell you about what we've designed for you, which is so exciting, it's responding to so many emails we've had over the last year, you will be able to see this again at your leisure. So I do apologize, keeping myself big. I thought I was small in the corner. Thank you, Jane, for just raising that. So let's get on to the next slide. As you know, I do all my tech myself, and it's not my forte, but I have a go. So let's think about some shoulder supporting structures, because the consequence of having a synovial joint, it's a synovial joint which is designed for movement, is now we've got a loose link. And if the forelegs are all about supporting against gravity because we have a loose link, it's now compromised. So we've got a range of supporting structures, but we need to know which ones are really important and which ones are sort of supplementary. So we've got the glenoid labrum, which is like a thickening around the rim of the glenoid cavity to make it a bit deeper. So if you look at the hip joint in the dog, it's got a really deep ball and socket joint. So that's actually a supporting structure in itself, the anatomical opposition. Whereas in the shoulder, it's such a huge humeral head. It's a very shallow cup. You haven't really got very much stabilizing in that anatomical fit. We've got the fibrous joint capsule, which people always underestimate. And I've got a really good story for a joint capsule. Think of a really thick woolly sock, cut off the toe end and cut off the other end. So it's kind of shaped and it's two free ends. A fibrous joint capsule is always forgotten as a stabilizing structure, and it's absolutely key. It literally goes to the periphery just after the articular surface on both long bones. So always have that in your mind, fibrous joint capsule, and that is lined by a synovial membrane. And the synovial membrane is very delicate. So that's not really a stabilizing structure, but it's fantastic at producing synovial fluid. And synovial fluid is brilliant at getting a frictionless joint, but also supplying nutrition to the articular cartilage. So everything's got its sort of place. If you need to review your synovial joints, we've got just the resource for you, and I'll tell you about it at the end of the presentation. We've also got the transverse humeral retinaculum, a fantastic bit of fascia, and it's really important to know all about that. So if you want the in-depth version of it, go and have a look at the webinar on biceps brachii, because we covered that extensively in there. And we've got the medial and lateral glenohumeral ligaments. A lot of contention about that. And we're going to discuss that a little bit in the next couple of slides. And then we've got the dynamic action of tendons of muscles around the joint. Now, if you remember, deeply placed muscles are more about stabilizing, and medially placed muscles are more about stabilizing, whereas your superficial muscles or your muscles placed laterally, they're all about dynamic movement. So you need stability to be able to move. So a hand drawing we've got here just to give you some idea, and then I was trying to hold the scapula in the same position and I couldn't. But essentially, the glenoid labrum, it extends that glenoid cavity, it becomes that glenoid lip, just to make the cup a little deeper. It's still not anatomically brilliant, but it improves it. So that's the supporting structure. The joint capsule, it's a loose fibrous sleeve in the shoulders. Some joints it's really snug, but here it's a loose fibrous sleeve and it attaches just peripheral to the glenoid lip. And then it attaches to the other long bone on the neck of the humerus. And I've got a picture coming up in a little bit just to show you. In fact, I think it was on here. So the pink arrow on the right, I hope you've got the picture up. I know it's a few seconds delay, but the pink arrow on the right is the neck of the humerus, which is on the caudal aspect of the humerus. So that's the neck of the humerus. And the green arrow on the left, that's identifying the shoulder joint, which lies equidistant halfway between the acromion and the greater tubercle of the humerus. And you can actually feel it when you're palpating with therapeutic handling. You can actually feel it's a very slight dent, like a little valley between those two bony landmarks. So just moving on to this joint capsule. The joint capsule is really loose, but it's a very strong supporting structure because it's made of connective tissue and it's fibrous. So it gives a lot of supporting, it gives a lot of support to the joint. And it blends in with the periosteum on the neck of the humerus. So it's unusual because in this joint, it goes just that little bit further along the humerus and blends in with the periosteum. And that's the sleeve that covers the bone. And that's what's really well innervated. So if someone kicks you in the shin, that's what you feel is your periosteum. It's not necessarily the bone, it's the periosteum because it's really well innervated. So in this picture, you can see the green arrow is just identifying the tendon of origin of biceps brachii, which is red on the left. And you can see, we're going to have a look at the transverse humeral retinaculum in a moment, but the joint capsule encapsulates like that woolly sock, but it can be different shapes as well. So here is that transverse humeral retinaculum. The joint capsule, and this is a really big clinical tip, the joint capsule cushions and surrounds and extends around the tendon of origin of biceps brachii. So it goes underneath it and around it, giving it that cushion of support, and it descends distally through the intertubercular groove. And to keep it in place is the transverse humeral retinaculum. And that's the green arrow, the teal arrow is pointing to the brown transverse humeral retinaculum on the left. And on the right is a diagram that we've put together. And again, don't worry if there's a lot to look on that. You can have access to that at the end when I explain what we've devised for you. So again, this is looking at that biceps brachii tendon of origin, because if you've watched the biceps brachii webinar, you know it is a major supporting structure of the shoulder joint. And if you look at how the limb is stacked with the dog when they're standing, it's at a slight angle and it's a major supporting structure on the cranial aspect. And it's all about support in stance. And that's why it's really important to look at your static treatment techniques. So it lies in the intertubercular groove between the greater and lesser tubercles of the humerus, and it descends down and it's held in place. Now you can have, another clinical tip, you can have a partial rupture of the transverse humeral retinaculum, and you can have a complete rupture, which is devastating. And that's very often linked with sesamoiditis of that limb as well, because you haven't got the structure held in place. So it becomes very inefficient. And then the foot balance changes, or what I would call the paw balance. I know most people say the foot balance. So the medial and lateral glenohumeral ligaments, these are fascinating. They're actually thickenings on the inside of the joint capsule on the medial and lateral aspect. So the joint capsule on the inside is kind of like irregular, and it's got these thickenings. It's fused to and thickened parts of the joint capsule. There's a lot of contention with research with this. Some people say they're really insignificant, they're not major supporting structures, and others have looked at research where they've severed the lateral glenohumeral ligament and the shoulder joint does sublux medially. But when you look at the size of them and their thickenings, that's showing you, maybe reflecting how important the joint capsule is rather than how important this structure is, because it's really small and fused and just thickened. It's like a thickened band on the internal surface of the joint capsule. So these are major supporting structures, and what fascinates me is how people learn their anatomy. So very often people start in the university courses on the forelimb, and they start with these muscles, superspinatus and also infraspinatus, that we'll look in a moment's time. And it's really important to remember these are deeply placed muscles. They've got muscles laying over them. You don't palpate them at all in life through the skin and fascia. You are actually palpating the muscles. So these are the deeply placed. Now that in itself and the architecture of these muscles should tell you something, that it's about stabilizing. So what is it important in stabilizing? Well, it's a short, stubby, thick tendon coming from superspinatus. I've kept it in yellow because normally I do it in the kind of gray-white, but I thought it would lose the attention because the joint capsule, it's laying on the joint capsule and it's fused. It's really fused and stuck to that joint capsule. And it's acting like a lateral collateral ligament, but it's a tendon. Now, where it's attached is to the greater tubercle on that round flattened area, just kind of behind the large part of the greater tubercle. So it's, you know, really working hard as a stabilizer of the shoulder joint. So now let's look at supraspinatus and infraspinatus. And what fascinates me as well is people think they're discrete little muscles laying in those fossas. They're not. They're big muscles that kind of blousy and bloom and go over the cranial border of the scapula. So when you feel the cranial border of the scapula, you know, on top of all the muscles, they're deep down there. And they kind of fuse and mash in with the muscle that's behind, which is subscapularis, which again is a really fascinating muscle. And then infraspinatus kind of blobs and fuses and blends with fascia, with teres major, and with the long head of triceps. So they're not polite muscles staying in their space. They kind of expand over. So supraspinatus, which is yellow, infraspinatus, which is green. You can see infraspinatus also has a really short, thick tendon, and both of these fuse to the joint capsule. They're very intimate with it, and they're acting like a lateral collateral ligament. So these two muscles, their main job is to be a stabilizer. They're not a mover and groover. They're a stabilizer of the shoulder joint. They can do other actions, but they're their minor actions. So we're looking at these supporting structures. So the joint capsule blends and fuses medially also with the muscle, which is on the costal surface. So I hope you can see the colors there, but the purple arrow is going to the costal, or the surface against the thorax, which is the medial aspect of the scapula. And subscapularis is a fascinating muscle with loads of pennate fibers packed in. It's medially placed and it's deep. So we know it's a major stabilizing muscle, but what's it stabilizing? Well, again, it's got this short, really strong tendon that is fused to the medial aspect of the shoulder joint. So we've got this ball and socket joint, but isn't it brilliant? It's actually working like a hinge joint because you've got these collateral ligaments either side. So the three main tendons that are dynamic are going to be your supraspinatus and infraspinatus tendons, not ligaments, tendons fused to the joint capsule and acting like a lateral collateral ligament for the joint, encouraging that beautiful sagittal plane movement and a hinge joint. So the joint is acting like a hinge, doing mainly flexion and extension, even though it's a ball and socket joint. The green arrows, they're pointing to the spinous scapula, the teal green arrows, and the acromion. So I wanted to talk about a muscle that lays on top of infraspinatus, and that's deltoid. Now, deltoid has two heads. It's got a scapular head that comes off the spine of scapula, and it's got an acromial head that comes off the acromion, and they fuse together and they attach where the blue arrow is. So the blue arrow, just there, just bringing it there, if you can see it. Okay, and that's the deltoid tuberosity. And the reason I'm telling you this is it's really important. That's like the lateral aspect, which is easily palpable, the lateral aspect of the humerus, not halfway down, just before, so about a third of the way down. And opposite that, on the medial side, which we can't palpate because of all the musculature, is the teres major tuberosity, where latissimus dorsi and teres major attach. So understanding the muscles in depth is great, but really getting an idea of how they're layered, what's on top of each other, what's in front, what's behind, and understanding none of these muscles can work discretely because they're so intimate with each other's fascia, and they actually arise off other muscles as well. So let's think about teres major and teres minor. Some people make a really big deal about these, but if you think about it, they're behind the axes of the shoulder joint, and they're like a V. So you've got teres minor, which is laterally placed, going to the proximal humerus at the top and coming from the caudal border of the scapula. And then you've got teres major, much bigger, which is on the medial aspect, but it acts like a V. So we've got a V. And what it's doing is, where its attachment on the humerus, it's actually all about supporting supraspinatus, infraspinatus, and subscapularis tendons, those collateral ligaments, and it's encouraging sagittal plane movement forward. Again, why are we going to do any techniques that walks a dog backwards or use reflexive techniques? Because we know from the makeup of the dog, we want to use rhythmical techniques as a priority always to activate the CPGs, and we want to map into the CPGs because that is predominantly how a dog moves. If this is new information for you or you're not sure where we are with this, just go and check out Natural Balance Motion. It's another webinar and it explains all of that for you. So these are about providing joint stability and maintaining that sagittal plane movement. It's making this ball and socket joint a hinge joint physiologically. So when we're thinking, so we've got our lovely model, Lily, and she's obviously you can see she's had her coat. She's been to the groomers, so she's feeling very buzzy and enjoying life so much. So the finger there, really when we're thinking biceps brachii muscle, look at the Bite-Sized Canine Anatomy series. It's the key stabilizing structure of the cranial aspect, and that kind of completes the shoulder joint stabilizing structures, the dynamic structures. And so when you're finding your shoulder joint in the right-hand picture, you can see my forefinger is on the greater tubercle of the humerus and my thumb is on the acromion. Halfway between there is the shoulder joint. And the picture on the left, my finger's just laying very gently on there. It feels like a bit of a dip, and it's like a V-shaped dip, and that's the shoulder joint, probably a little bit more proximal than some people realize. And that's very important when you're doing two-point control, movement therapies, or you're doing any kind of movement shaping, because that would be where you would balance out and position yourself to give you power over guiding the motion therapeutically. So when you're palpating this joint, it's really important to use therapeutic handling and therapeutic touch. Please work with the dog, not on the dog. You know, if you rub your hip or without banging it and you just rub your hip bone, it aches the next day. So over palpation can cause a lot of problems. And also there's a way to therapeutically use therapeutic touch when you're palpating. We're not just going to go there and try and mash around and press hard and find it. We're going to go find those bony landmarks. We're going to look at the bony landmarks around, and we're going to geographically have those signposts to help us quietly with therapeutic handling go to there. And the reason that's so important is that we know definitely that the dog's muscle tone and fascial tension changes with their emotions. So if they're stressed, anxious, if you haven't got them calm and focused, you're going to get misinformation. So for accurate palpation, for accurate location, work with the dog, use therapeutic handling, movement enrichment techniques, and therapeutic touch, please. So any questions? We've got a question there. I'll bring that up. So I'm just going to start answering. I'm just time stamping it. So the question, oh, it's a lot. My youngest dog, now 7 years old, has always been in a laying down position, placed her lower leg and paws out at 45-degree angle. She is fit and fast, but when the vet osteopath attempted to manipulate her front legs, she was having none of it. I'm guessing she's holding her shoulders in some way for some reason. Am I thinking in right direction here? What might be happening? You know, without a thorough assessment, I can't really speculate. But the main thing is when you're working with your dog and you're doing mobilizing and manipulation techniques, you need to work with the dog using therapeutic handling, therapeutic touch. So without an assessment, I can't make a judgment, and I'm really sorry. I'm really sorry for that, Bernadette. But that might be something you could PM me and we could discuss a little bit more, because then you could give me a bit more detail than I've got on there, and I'm sure I can help you. I hope that helps, Bernadette. Sorry I'm not dodging that, but it's just not enough information. So for those of you who've come in to have a look, to review, because your anatomy is tip-top, that's fantastic. I've given all the information now that I'm going to give, so you're really welcome to sign off. But the next bit is specifically for the people who email me. We're so grateful for your questions, your emails. I want to tell you about the new development we've been working on really hard for the last couple of weeks, and especially at this very unusual and challenging time, to give you something back. So sign out anybody who's not going to be applying for their CPD certificate, who's not really interested in having an additional resource. And if you are interested, let's look at the next slide. So, because we're really excited with what we've created, and you know us, it's a little bit different. Whoops, I've missed the slide. There we go. So I'm just going to come onto this slide. We have designed, using some new tech, a new bite-sized anatomy hub for you. And this has got all the Canine bite-sized anatomy series on it. It has got the webinar, it's got the PDFs, all the people who email me and say, please, could we have a copy of your presentation slides? It's got that. It's also got really interesting visuals, some more clinical top tips. It's structured the way we structure our courses in like very sort of chunked down information. We've got some more pictures that you haven't had in the presentation, and some really nice design features. A lot more on triceps and quadriceps, because triceps brachii is the key functional muscle of the forelimb, as you know, and quadriceps femoris is the key functional muscle of the pelvic limb or the hind limb in the dog. So this is something we're going to give you a link. And this is somewhere you can go if you're interested in having this resource. It kind of answers all the questions that you've channeled at us for several months now. So click on the link. This will take you to what's called a Notion page. Now, this isn't just any old PDF. This is like a Harry Potter piece of resource. It is pages within pages, and we can add into the resources already there, and then each time we do a webinar, we're going to add that in as well. So the shoulder joint PDF is already there with an informative blog, more visuals for you to have a look at. So if that's something you're interested in because you feel that these are of value, if you find these presentations of value and you feel it's of value for you, please go ahead. If you feel we've covered everything and you knew it anyway, don't worry at all, it's not for you. But this is for the people who have built this community of emailing us regularly, really want to progress their functional anatomy. And so we've just designed it, and it's going to grow. Now, if you want more webinars, if you want this to expand and become a real hub of information as we progress over the year, please, I would like to invite you to buy me a coffee. Now, buy me a coffee is a new thing as well that I'm not sure the UK has really come across. But essentially, if you feel what we've done tonight and the hub full of information, all extra resources, is worth a coffee to you, please buy me a coffee. There's a link at the bottom of the page, and we are committed to keeping all our coffee money that you send so we can keep paying for this tech and keep producing this, because this is going all over the world. So it's just brilliant, this community we're building. So I hope, and you can buy me 3 coffees if you want. Coffee's £3. So if you're feeling this is of value to you and you'd like to access the additional resource, please, I invite you to buy us a coffee. We've also got a YouTube channel, so all these webinars are being put on there. And thank you so much for subscribing. I'm so grateful that you're so interested in anatomy and clinical tips and just getting information out there for everyone to share. So please, if you haven't had a chance to visit that, do have a look. We do upload. I'm going to be uploading some new videos there. So people who subscribe, you'll get a bell to let you know. We're going to do some more bite size about what you need to do now you're in shutdown, your hydrotherapy center, some top tips, what you need to be doing weekly or getting someone to do to keep everything at its best for when you go back into practice. And the last thing is, if you want to claim those free CPD certificates, which people who are using these resources will, obviously, if it's not for you, you're not going to claim the free CPD certificate, but those that want to record their progression with canine anatomy, functional anatomy, you're very welcome to go to the Canine HS website, go along the top navigation bar, click on resources, and it's there. I can guarantee you I will get at least 20 inquiries, where do I get my CPD certificate? So it's on the Canine HS website. So again, you know, I'm really, really excited about this journey with you. And please, you know, let us know if this is interesting for you, if it's going to be useful for you. And please, if you're going to use our resources, do buy us a coffee so we can invest that into keep going and expanding more exciting pages. And as I said, it's a Harry Potter page because we can add to the page while you watch in another part of the UK, in another country. So we'll also flag up when we add additional information to the webinars we've already had. So I hope you have a great evening. Thank you so much for joining me. We've absolutely filled the house today. And the last thing, just to let you know, if you're still listening, we've launched the next one in 2 weeks' time. It's just gone live this afternoon. We have 100 free spots. And I would love you to have one of those 100 free spots. So when it goes over 100, those people, you know, it's not easy to access. So for the live event, there's 100 free spots. Please book your spot now. I'll give you the link for the resource, the hub, and I'll give you the link for the newly released one, which is going to be on the gluteal muscles. Really important. They're the powerhouse along with the hamstrings for the dog. So let's really look at those in a couple of weeks' time on 19th of April at 7 p.m. See you then. Thank you very much for attending, and I really look forward to your emails, and I'm so grateful for your feedback. We just so appreciate all the input, and we're so grateful for all the emails, questions, and feedback you give us. So do let us know if you're still enjoying these. Many thanks.